Welcome to the Deep Dive, where we sift through the latest articles, research, and expert notes to bring you the most vital nuggets of knowledge, custom tailored for you. Today, we're plunging into the high-stakes world of emergency medicine, specifically where the body's largest artery, the aorta, can suddenly become a battleground. Imagine, if you will, a sudden, excruciating pain. It could signal one of two vastly different yet equally life-threatening vascular emergencies. It's a real diagnostic challenge.
Oh, absolutely. These conditions often mimic each other, and they demand incredibly precise and rapid responses.
It's a remarkable testament to the body's intricate design, isn't it? And its vulnerabilities, too.
It really is. The urgency in these situations, it's
Yeah.
excellent. Accurate, swift diagnosis isn't just a goal. It's often the only path to a patient's survival.
Absolutely. So our mission for this deep dive is to unpack these two critical conditions, aortic dissection and abdominal aortic aneurysms. We'll explore their unique features, try to understand why they're so often confused, and really appreciate the critical importance of getting the diagnosis right and right away.
And to guide us through this pretty complex terrain, we've drawn from comprehensive medical textbooks, success topic guides used for medical exams, and also invaluable insights from the International Registry of Acute Aortic Dissection, which is known as IRAD.
Right, IRID, that really shows how real-world data shapes our understanding.
Exactly. It's crucial stuff.
So let's start with the first of these hidden dangers, aortic dissection. We're calling this the tearing truth because, well, it's literally a tear that unmasks a profound urgency. But what exactly is tearing inside?
Okay, so think of your aorta, that main artery leaving your heart, kind of like a hose pipe made of three distinct layers. An aortic dissection, or AD, happens when the innermost layer, that smooth, thin lining called the intima, gets a tear. When that tear occurs, blood under high pressure rushes into the wall itself, forcing its way between the inner and middle layers. This creates a new sort of false channel for blood flow within the wall. It's not just a bulge, it's an internal structural failure, you see.
And our sources really hammer home that this distinction is crucial. A dissection is not an aneurysm. You even hear the term dissecting aneurysm sometimes, but that's actually incorrect, isn't it?
That's a vital point, yeah. The term dissecting aneurysm is, well, it's a misnomer because the underlying problem, the pathology, is fundamentally different. Like you said, an aneurysm is a ballooning or dilation of the vessel wall. A dissection is a tear that splits the wall layers.
Gotcha.
Conflating the two can lead to confusion and understanding, and maybe more importantly, in treatment strategy.
Right. So once this devastating tear occurs, how do medical professionals categorize it? And why does that classification matter so much for treatment?
Well, the primary system used is the Stanford classification. It's pretty straightforward. Stanford type A involves the ascending aorta, that's the part closest to the heart, and it might or might not extend further down the vessel. Stanford type B involves only the descending aorta, so it doesn't involve that ascending portion near the heart.
Oh.
There's also another system, the DeBakey classification, which looks more at the overall extent, the start and end points of the dissection. But these classifications aren't just academic exercises. They directly dictate the treatment strategy.
Oh, so?
For instance, type A dissections, the ones involving the ascending aorta, almost always require immediate open heart surgery, whereas type B dissections, the descending ones, often begin with medical management, first controlling blood pressure and heart rate.
So a tear in the body's main artery. It sounds truly catastrophic. Who are the people most vulnerable to something like this? I'm guessing hypertension is a big factor.
It is, definitely.
Mhm.
The sort of typical patient profile is someone in their 50s with essential hypertension. That's present in about 70% of cases. Over time, that sustained high blood pressure can weaken the aortic wall, making it more susceptible to tearing.
And it's not just about age, is it? We often think of these conditions as affecting older adults, but our sources point to some maybe surprising risk factors for younger individuals too.
That's a really critical area, yes. For younger patients, aortic dissection is often linked to underlying genetic or structural conditions. Connective tissue disorders like Marfan syndrome, for example, are present in something like 50% of dissections in patients under 40. It's quite striking.
Wow, half.
Yeah. And then there's Ehlers-Danlos syndrome, having a bicuspid aortic valve, where the valve only has two leaflets instead of the usual three, or even a narrowing of the aorta called coarctation. These can all predispose someone.
Any other risk factors?
Yes. A family history of aortic aneurysm or dissection is significant. Pregnancy can increase risk, Turner syndrome too, and even acute stressors like, say, recent very heavy lifting or cocaine use have been linked.
Okay, so if someone is experiencing an aortic dissection, what are they likely to feel? What's the key symptom that doctors are really looking for?
The most common symptom, by far, in about 85% of cases, according to the IR data we mentioned, is incredibly severe pain. But it's not just any pain. It's almost always abrupt in onset, like really sudden.
Sudden how?
Patients can often pinpoint the exact second it started. And crucially, it usually reaches its maximum intensity immediately, right at the start. This sudden, severe, often described as ripping or tearing chest or back pain. That's a huge red flag for dissection.
So it's the character and the onset, not just how bad it feels.
Exactly. It's less about the overall severity score, maybe, and more about that abruptness and the tearing nature that really guides suspicion. It's almost like the body is screaming, something just ripped.
And does where the pain is located give clues to?
It often does, yeah.
Yeah.
Anterior chest pain, pain in the front of the chest, often signals an ascending or type A dissection. That happens about 70–80% of the time with type A. If the pain is primarily between the shoulder blades, what we call interscapular pain, that usually points more towards a descending or type B dissection.
Interesting.
And what's also striking is that the pain can sometimes migrate, move through the chest or into the abdomen as the dissection actually propagates, as the tear extends down the aorta.
But what about patients who don't present with this classic excruciating pain? That sounds like it would make diagnosis incredibly difficult, a real nightmare.
It absolutely is, and it happens in a significant minority, maybe 5–15% of patients. They might present with fainting, which we call syncope, or perhaps stroke-like symptoms if a brain artery is affected, or even signs of sudden heart failure. Elderly patients in particular often have these more atypical presentations.
So you can't hang your hat on pain alone.
Definitely not. It's crucial to remember that no single symptom is definitive. There's a lot of overlap with symptoms from cardiac issues, pulmonary problems, abdominal conditions, even musculoskeletal disorders. That's why the whole clinical picture is just so important.
Okay. Beyond the initial pain, or maybe lack of pain, how does an aortic dissection impact the rest of the body? What are the sort of systemic consequences of this tear?
Oh, the consequences can be devastating and really widespread, mainly because the aorta supplies blood to virtually every organ. The most immediate and feared complication is rupture. The weakened wall can just burst.
Burst where?
It can rupture into various body cavities. For instance, bleeding into the sac around the heart, called hemopericardium, can lead to cardiac tamponade and sudden death. Bleeding into the chest cavity itself, a hemothorax often on the left side for descending aorta ruptures, is also rapidly fatal. Or it could rupture into the space behind the abdominal organs, causing a retroperitoneal hemorrhage if the tear extends down that far.
So massive internal bleeding, but it's not just bleeding out, is it? The tear can also cut off blood supply to vital organs.
Precisely. That's the other major mechanism of damage, occlusion of branch vessels that come off the aorta. This can lead to what we call distal organ ischemia, basically. Organs downstream aren't getting enough blood.
And that could show up in many different ways, I imagine.
Hugely varied ways. It could cause a heart attack, a myocardial infarction, if the coronary arteries supplying the heart muscle are involved. It could cause a stroke if the carotid arteries to the brain are affected. An acutely ischemic limb, sudden severe pain and coldness in an arm or leg if a subclavian or femoral artery is cut off. Or ischemic bowel if the celiac or mesenteric vessels supplying the gut are compromised. You might see acute kidney failure if the renal arteries are blocked. Or even, quite dramatically, sudden onset, painless paraplegia paralysis of the legs if the spinal artery supply is interrupted.
Wow. So doctors need to check pulses everywhere.
Yes, clinicians actively look for pulse deficits or a significant blood pressure difference, say 20 millig or more between the two arms. But it's really important to note these signs only occur in about 20% of patients, so their absence definitely doesn't rule out a dissection.
Okay. And what about the heart itself? How does this affect the heart's function directly?
Well, the dissection can also lead to acute or progressive aortic regurgitation. This happens if the tear extends right back to the aortic root, disrupting the aortic valve and preventing it from closing properly. Blood then leaks backward into the heart with each beat, which can rapidly lead to symptoms of heart failure, like shortness of breath.
Given how varied and severe these presentations can be, what's the diagnostic process like in the emergency room? Where do doctors even start?
Well, the initial steps often include things like a chest X-ray and ECG to check the heart's electrical activity, and maybe cardiac enzyme blood tests. However, this is key. These initial tests have significant limitations for diagnosing dissection.
How so? The ECG, for example.
Well, an ECG is only completely normal in about 30% of patients who actually have a dissection. Worse still, it can sometimes even show patterns that look like a classic heart attack, what we call ST elevation myocardial infarction, or STEMI, that occurs in about 3% of AD cases, or other acute ischemic changes in maybe 15%.
That sounds dangerous if you misinterpret it.
Extremely dangerous. Because if a heart attack is suspected based on the ECG, the standard treatment involves blood thinners or clot-busting drugs, thrombolysis. But if the underlying problem is actually an aortic dissection, giving those treatments can be catastrophic. They can cause uncontrolled bleeding from the tear and significantly worsen the outcome.
So extreme caution is needed if dissection is even a possibility.
Absolutely. If AD is suspected, antiplatelet therapy or thrombolysis should be withheld until it's ruled out.
And the chest x-ray, that seems like a go-to for chest pain. How useful is it here?
It's a common initial test, yes, but it's definitely not reliable for making a definitive diagnosis of dissection. And it should never delay getting more advanced imaging if your suspicion is high. That being said, an abnormal chest x-ray is present in a majority of cases. The sensitivity is somewhere between 60 and 90%. Clinicians might look for suggestive signs like a widened mediastinum, the space in the middle of the chest, or an abnormal aortic contour, maybe fluid around the lungs suggesting a hemothorax.
But a normal one doesn't mean you're clear.
Not at all.
Yeah.
A normal chest x-ray absolutely does not rule out an aortic dissection. That's a crucial take-home point.
So it sounds like it's a really tough diagnosis to make initially, based on those first tests. How do clinicians then try to narrow down the possibilities or quantify the risk?
That's where clinical risk stratification tools come into play, like the Aortic Dissection Detection Risk Score, or ADDRS. It's a structured way to assess risk based on the patient's presentation. It assigns points based on 3 categories.
Okay, what are they?
First, high-risk pre-existing conditions. Things like Marfan syndrome, a known family history of aortic disease, known aortic valve problems, recent aortic surgery or manipulation, or a known thoracic aortic aneurysm. Second, high-risk pain features. That abrupt onset, severe intensity, ripping or tearing quality we talked about, whether it's in the chest, back, or abdomen. And third, high-risk physical exam findings. Evidence of poor perfusion like a pulse deficit, that systolic blood pressure difference between arms, any new neurological deficit along with the pain, a new murmur suggesting aortic regurgitation, or signs of hypotension or shock.
And how does the scoring work?
It's simple. 0 points is considered low risk, 1 point is intermediate risk, and more than 1.1 is high risk. What's really important here is that studies like from IARD show about 95% of patients ultimately diagnosed with AD fall into the intermediate or high-risk categories based on this score. So it helps guide who needs urgent imaging.
And D-dimer, that blood test often used for blood clots, plays a role here too, right?
Yes, it does, but with caveats. D-dimer levels are typically elevated in acute aortic dissection. It's quite sensitive, around 96% sensitive to the standard 500 ng/mL cutoff, but it's very nonspecific. Many other conditions like pulmonary embolism, deep vein thrombosis, infection, inflammation, even just being older or hospitalized can also cause an elevated D-dimer.
So a positive D-dimer doesn't confirm dissection.
Not at all. Its real value is actually as a rule-out test, particularly in low-risk patients. A negative D-dimer in someone deemed low risk by the EDDRS score can be very useful for helping to exclude AD.
Is there data supporting that combination?
Yes, the ADVISED study, which was a prospective multi-center trial, looked at exactly this. It showed that combining an ADDRS score of 1 or less, so low or intermediate risk, with a negative D-dimer, less than 500 NELOL, was 98.8% sensitive for detecting acute aortic dissection. This suggests that this combination could potentially help avoid unnecessary CT scans in a significant number of lower-risk patients presenting with chest pain.
Okay, that makes sense. So when clinicians do need that definitive answer, when the suspicion is high or intermediate, what's the absolute go-to imaging modality?
Computed tomography angiography, or CTA, that's really the workhorse, the gold standard for diagnosis in most centers. It has excellent sensitivity, usually quoted as over 90%, and specificity over 85%. It provides clear, detailed cross-sectional images that directly show the key feature, the intimal flap separating the true lumen from the false lumen within the aortic wall, and it visualizes the full extent of the dissection, which is vital for classification and planning treatment.
Are there other imaging options used?
Yes. Other modalities have roles. Transthoracic echocardiography, or TTE, that's an ultrasound of the heart done through the chest wall, can also be done quickly right at the bedside. You can sometimes identify the intimal flap, especially in type A dissections, maybe 80% sensitive there, less so for type B, around 50%. It's also good for detecting complications like pericardial effusion or aortic regurgitation, but it shouldn't delay getting a CTA if suspicion remains high.
What about TOE, transesophageal echo?
Transesophageal echocardiography, TOE, where the probe goes down the esophagus, offers even higher sensitivity, maybe 90–98%, and gives very detailed views, particularly the ascending aorta and valve. However, it's more invasive, requires sedation, isn't always readily available, and the procedure itself can sometimes cause blood pressure surges, which isn't ideal in dissection.
Any others? MRI.
MRI, angiography, MRA, is also highly accurate, similar to CPA, but it takes much longer and isn't usually practical in the acute emergency setting. Old-fashioned catheter aortography is rarely used for diagnosis now due to its invasiveness and the superiority of CTA and MRA. So really, CTA is king in the acute setting.
Okay. So once that diagnosis is confirmed, let's say by CTA, how do medical teams manage these incredibly critical, life-threatening events? What are the immediate steps?
Right, so the initial management involves general resuscitation protocols following local guidelines,
Yeah.
ABCs, supplemental oxygen, establishing IV access, monitoring vital signs closely, hemodynamic support if needed, and pain control is crucial, usually with intravenous opioids like morphine or fentanyl. This isn't just for the patient's comfort, although that's important. It also helps to reduce the sympathetic nervous system response, the fight-or-flight reaction, because stress and pain can worsen the dissection by increasing heart rate and blood pressure, putting more stress on that torn aorta.
And there's something called anti-impulse therapy that's absolutely vital, isn't it? It sounds like it's about slowing the heart down and reducing the force of the heartbeat to prevent further damage.
That's exactly right. You've got to reduce the hydraulic stress on the aortic wall. Imagine that tear. Every time the heart beats forcefully, it sends a powerful pulse, a shock wave, down the aorta, slamming against that weakened, dissected wall. This force is called DPDT, the rate of pressure rise. Anti-impulse therapy is designed to dampen that pulse, reducing both the force, DPDT, and the frequency, heart rate, with which blood impacts the torn area. It's crucial for both type A and type B dissections in the acute phase.
So how is that achieved? What drugs are used?
Intravenous beta blockade is the absolute first-line treatment. The goal is to rapidly lower the heart rate to a target of less than 60 beats per minute and also lower the systolic blood pressure, ideally to less than 120 mmHg, or the lowest tolerated pressure that maintains organ perfusion. Esmolol is often considered a great choice because it has a very rapid onset and a short half-life, meaning you can titrate it easily and stop it quickly if needed. Labetalol, which has both beta and alpha blocking properties, is another common option.
What if beta blockers alone aren't enough to get the blood pressure down?
Right, if beta blockade alone doesn't achieve the target blood pressure, then a vasodilator should be added, something like sodium nitroprusside, or perhaps a calcium channel blocker like nicardipine. But, and this is a critical point we have to emphasize, vasodilators should never be given alone before beta blockade is established.
Why not?
Because vasodilators, by lowering peripheral resistance, can cause a reflex increase in heart rate and contractility. That means the heart beats faster and more forcefully, increasing that DPDT, that shearing stress on the aorta, which could potentially worsen or extend the dissection.
Ah, I see. So beta blockers first to control the force and rate, then vasodilators if needed for pressure?
Exactly. Beta blockade first is the rule.
And then do the treatment paths diverge significantly depending on whether it's a type A or type B bisection?
Yes, this is where that Stanford classification becomes immediately actionable and dictates the definitive management strategy. Type A dissections, the ones involving the ascending aorta, are considered surgical emergencies. They demand urgent, usually open surgical repair, which involves replacing the diseased segment of the ascending aorta, sometimes involving the aortic arch or valve as well.
Why the urgency for type A?
Because they carry an extremely high risk of rupturing into the pericardial sac surrounding the heart, leading to cardiac tamponade and death. The mortality rate for unoperated type A dissection is often quoted as rising by 1–2% per hour in the first 24–48 hours. It's incredibly lethal.
Wow.
Tragically, many patients still succumb while awaiting surgery or during the operation itself. It's a very high-risk situation.
And what about type B, the descending aorta ones?
For uncomplicated type B dissections, meaning those without signs of rupture, malperfusion, persistent pain, or uncontrolled hypertension, the initial management is usually medical. This focuses on meticulous ongoing blood pressure and heart rate control, that anti-impulse therapy we discussed, and adequate pain relief. Patients are typically admitted to an intensive care unit for close monitoring.
But what if they are complicated?
Right. For complicated type B cases, those with refractory pain, persistent high blood pressure despite maximal medical therapy, signs of rupture, like a hemothorax, evidence of organ or limb ischemia, malperfusion, or rapid expansion of the aorta on imaging, then intervention is usually necessary. Increasingly, the preferred approach for complicated type B is endovascular intervention, specifically TEVAR, which stands for thoracic endovascular aortic repair. This involves placing a stent graft inside the aorta via catheters inserted through arteries in the groin, essentially relining the aorta and covering the entry tear.
So less invasive than open surgery for those cases.
Generally, yes, though open surgery remains an option if endovascular repair isn't feasible.
Now, there's a really interesting, almost counterintuitive detail you mentioned earlier, a critical safety point from the sources about managing patients who have hemopericardium, that bleeding around the heart from a dissection. Can you expand on that?
Yes, this is an extremely important safety pearl that everyone involved in emergency care should know, as it can make a life-or-death difference. Even if a patient with an aortic dissection has blood in the pericardial sac, causing cardiac tamponade, where the heart is being dangerously squeezed by the fluid performing pericardiocentesis, which is draining that fluid with a needle, is generally strongly discouraged or should only be done with extreme caution, often in the operating room setting just before surgery.
Why is that? Normally, draining tamponade is life-saving.
It is in most contexts, but with an aortic dissection causing the tamponade, the situation is different. That contained blood in the pericardial sac is actually providing some back pressure, helping to tamponade the leak from the aorta itself. If you rapidly drain that pericardial blood, you suddenly decrease the pressure outside the aorta. This drastically increases the pressure gradient across the tear in the aortic wall. The result can be immediate, torrential, and catastrophic bleeding from the dissection site into the now decompressed pericardial space, leading to sudden cardiovascular collapse and likely death.
Wow. So relieving the tamponade can actually worsen the underlying problem in this specific scenario.
Exactly. It's a very specific, very high-stakes situation where the usual life-saving procedure can be lethal. Definitive surgical repair is the priority.
Okay, that's a critical point. All right, that brings us to our second major condition, which, as we said, can look very similar on the surface. Abdominal aortic aneurysm, or AAA. We're calling this the silent danger.
So first off, how would you define an AAA, and how is it fundamentally different from the dissection we've just discussed?
Right. So an abdominal aortic aneurysm, or AAA, is a permanent pathological dilation, basically a ballooning or widening of the aorta, specifically in the abdominal segment. It's generally defined as having an outer diameter of 3 centimeters or more, or alternatively being more than 1.5 times the normal expected diameter for that section of the aorta in that individual. And importantly, more than 90% of these AAAs originate below the level of the renal arteries, the arteries supplying the kidneys.
So completely different from dissection, not a tear within the wall, but an outward bulging of the entire wall. Precisely. The wall layers remain intact, but they're weakened and stretched out over time, leading to this dilation. The underlying pathology is usually atherosclerosis, hardening of the arteries, often associated with risk factors like smoking, age, male sex, and family history.
And the danger here is primarily the risk of rupture, right? You called it the silent danger because they can be completely asymptomatic until they burst. That sounds terrifying.
That's exactly why it gets that name. Most AAAs are completely asymptomatic and are often discovered incidentally, perhaps on an ultrasound or CT scan done for some other reason. For these asymptomatic unruptured AAAs, the management strategy is typically surveillance. We monitor the size with regular imaging, usually ultrasound. Elective repair, either open surgery or endovascular repair, EVAR, is generally recommended when the aneurysm reaches a certain size threshold, typically around 5.5 centimeters for men, or if it's growing rapidly or causing symptoms. This is done when the estimated risk of rupture outweighs the risks associated with the repair procedure itself.
But what happens when they do rupture?
A ruptured AAA is a true surgical emergency with an extremely high mortality rate, often exceeding 50%, even if the patient reaches the hospital. The classic presentation, though not always present, is often described as an older male, typically a smoker with known atherosclerosis, who suddenly develops severe acute pain, usually in the back or abdomen. This is often accompanied by hypotension, a rapid drop in blood pressure leading to shock, and sometimes a pulsatile abdominal mass, meaning you can feel a prominent pulse when examining the abdomen.
But the presentation isn't always that classic triad.
No, it can be quite varied. Patients might just present with fainting or syncope due to the blood loss. The pain might be localized differently, maybe just in the flank, the groin, or the hip. It can sometimes mimic other conditions like kidney stones or diverticulitis.
And you mentioned earlier, somewhat surprisingly, that although AAAs are less common in women, they actually face a higher rupture risk if they do have one.
That's right. While AAAs are significantly more prevalent in men, maybe 4 to 6 times more common, female sex is recognized as an independent risk factor for rupture. This means that for a given aneurysm size, a woman's individual risk of rupture is generally considered higher than a man's. This might influence the threshold size at which elective repair is considered for women, sometimes slightly smaller than for men.
Okay. So if a ruptured AAA is suspected in the emergency department, what's the diagnostic approach and how is the initial management perhaps different from other types of shock or trauma?
If a ruptured AAA is strongly suspected based on the clinical presentation, particularly in an unstable patient, the immediate diagnostic step might actually be bypassed in favor of going straight to the operating room if vascular surgery is available on site. Time is critical. However, if the diagnosis is less certain or the patient is more stable, the immediate diagnostic test of choice is usually a bedside abdominal ultrasound. It's quick, non-invasive, readily available, and has a very high sensitivity, over 90%, for simply identifying the presence of an AAA. It might also show free fluid in the abdomen suggesting rupture.
What about CT scans?
For patients being evaluated for elective AAA repair, or in stable patients where the diagnosis of rupture is uncertain, thin-slice contrast-enhanced CT angiography is the standard imaging modality. It gives detailed anatomical information needed for planning the repair. In the context of suspected rupture in a relatively stable patient, CT can confirm the rupture and help plan the approach.
And the initial management in the ER for a suspected rupture?
It's focused on prompt resuscitation, but with a specific caveat. You follow the standard principles, ensure a secure airway, intubation if needed, establish 2 large-bore 5E lines for access, draw blood for a full blood count, electrolytes, kidney function, glucose, coagulation studies, and crucially, cross-matching for urgent blood transfusions. Pain relief with IV analgesia and antiemetics for nausea are also important.
But there's a crucial difference in how fluids are given compared to, say, managing bleeding from trauma.
Yes, this is a critical distinction often referred to as permissive hypotension or hypotensive resuscitation. Unlike many other forms of severe hemorrhage, where the immediate goal is to rapidly restore normal blood pressure with aggressive fluid resuscitation, with the suspected ruptured AAA, excessive intravenous fluid administration should generally be avoided unless the patient is in profound shock.
What's the reason for that?
The rationale is that aggressively raising the blood pressure with fluids might dislodge any fragile clot that is formed at the rupture site, potentially converting a contained rupture into catastrophic free hemorrhage. So the goal is often to accept moderate hypotension, typically aiming for a systolic blood pressure, maybe around 90 mmHg, or just enough to maintain consciousness and vital organ perfusion until surgical control of the bleeding can be achieved.
So keep them alive, but don't pop the clot.
That's the basic idea, yes. Of course, ensuring blood products, packed red cells, plasma, platelets are readily available, or being transfused according to massive transfusion protocols is paramount. And getting the vascular surgery team involved extremely early is absolutely critical.
And speed is of the essence for getting the patient to definitive care, too.
Absolutely. There's a strong emphasis now on streamlined pathways and collaboration between emergency departments, ambulance services, and the regional vascular centers that perform these emergency repairs. National guidelines often state that patients with the suspected ruptured AAA should ideally depart the referring hospital emergency department within 30 minutes of the decision to transfer to the vascular unit. Every minute counts.
Makes sense. What kind of complications can arise from AAAs, both from the condition itself before rupture and perhaps after treatment, whether it's open or endovascular repair?
Well, beyond the overwhelming danger of rupture, unruptured AAAs can occasionally cause complications like distal embolization, where small clots form within the aneurysm sac and travel down to block arteries in the legs or feet. They can also cause symptoms by compressing adjacent structures. Rarer but life-threatening complications include those fistulas we touched on. Aortoteric fistulas, where the aneurysm erodes into the bowel, typically the duodenum, causing potentially massive gastrointestinal bleeding. And aortocoval fistulas, where it erodes into the inferior vena cava, leading to high-output cardiac failure and limb swelling.
And after repair, what are the common postoperative issues?
After surgical repair, either open or endovascular, a range of complications can occur. Following major open surgery, things like abdominal compartment syndrome, a dangerous buildup of pressure within the abdomen can happen. Paralytic ileus, where the bowel stops working temporarily, is common. Acute kidney injury is also a risk due to clamping in the aorta or contrast dye used in EVIA. Limb ischemia can occur if the repair compromises blood flow to the legs. Spinal cord ischemia leading to paraplegia is a rare but devastating complication, more common after repair of more extensive thoracoabdominal aneurysms, but can occur with infrarenal AAA repair too. Graft infection is a serious long-term complication, though thankfully rare. And specifically after endovascular repair, EVR, the main ongoing concern is endoleak.
Endoleak, what's that?
Endoleak is defined as persistent blood flow into the aneurysm sac outside of the stent graft itself. There are different types depending on where the leak is coming from. While the immediate procedural risks of EVAR are often lower than open surgery, endoleaks require lifelong surveillance with imaging, because some types can allow the aneurysm sac to continue pressurizing and potentially rupture later on. The rate is significant. One source mentioned around 4.7% after thoracic endovascular repair, and it's a known issue with abdominal EVAR too, requiring monitoring and sometimes reintervention.
Okay. So we've walked through the specifics of aortic dissections and abdominal aortic aneurysms in quite some detail. Let's try to bring it all together now in our final section, the critical distinctions and takeaways. Why is it just so crucial to distinguish between these two conditions, especially given that they can both present with overlapping symptoms like severe pain and shock?
It really comes down to that fundamental pathology we discussed. While both are life-threatening emergencies involving the aorta, one is a tear, a separation within the layers of the aortic wall that's dissection. The other is a ballooning, a dilation of the entire wall that's an aneurysm. And this distinction is absolutely critical because it dictates entirely different and often diametrically opposite immediate treatment strategies. Getting it wrong can be fatal.
Can you give the key example again?
Sure. The classic example is the Stanford type A aortic dissection. This generally requires urgent, complex open-heart surgery with cardiopulmonary bypass because of that imminent risk of rupture into the pericardial sac. You need to replace the torn segment. In contrast, many unruptured abdominal aortic aneurysms are initially just observed with regular scans. And even a ruptured AAA, while also a dire surgical emergency requiring prompt intervention to stop the bleeding, the repair itself, whether open or endovascular, typically does not require cardiopulmonary bypass and targets a different problem, controlling hemorrhage from a dilated burst vessel, not fixing a tear within the wall layers near the heart.
So the path to saving a life is profoundly shaped by correctly identifying which of these two conditions is actually present.
Precisely. Misdiagnosing a type A dissection as something else, or delaying surgery, is often lethal. Conversely, rushing an asymptomatic stable AAA patient to surgery carries unnecessary risks. Accurate diagnosis is everything.
So despite their differences, what shared principles emerge from managing both of these high-stakes conditions? What are the sort of universal truths for doctors racing against the clock in these scenarios?
I think there are a few key shared principles. First, early suspicion based on a thorough patient history and a high index of suspicion is paramount. You have to think of these conditions to diagnose them. As we've seen, they can present deceptively, and classic physical signs might be absent or misleading. So history is key, the nature of the pain, risk factors.
Right. Don't rely just on the exam.
Exactly. Second, aggressive hemodynamic control managing both blood pressure and heart rate is crucial for stabilizing the vessel in both conditions, at least initially. Though, as we discussed in detail, the specific targets and the sequence and type of medications used are tailored. For instance, that critical beta blocker's first rule for dissection doesn't apply in the same way to AAA management, where permissive hypotension might be the goal in rupture.
Got it. Control hemodynamics, but do it intelligently based on the suspected condition.
Correct. And finally, definitive imaging, primarily CT angiography in the acute setting, is the cornerstone of diagnosis for both conditions. It's what ultimately confirms the diagnosis, clarifies the exact nature and extent of the problem dissection versus aneurysm, type A versus type B, ruptured versus intact, and guides the subsequent life-saving interventions, whether they be medical, endovascular, or surgical.
Okay, well, we've certainly navigated the complex and rather intimidating high-stakes world of aortic emergencies today. Hopefully you listening now feel you've got the key insights into aortic dissection and abdominal aortic aneurysms, two conditions that truly demand speed, precision, and a deep understanding of those nuanced differences.
It really is sobering when you consider the astounding speed at which a seemingly healthy individual can become critically, desperately ill from one of these aortic catastrophes. It underscores the hidden vulnerabilities that can exist within our own bodies and highlights the immense pressure on medical professionals to make rapid, accurate diagnoses when symptoms can be so confusingly similar or atypical.
It really does. And maybe a final thought for you to ponder. What stands out to you about how the smallest details encountered in the ER, like the precise description of pain onset, that ripping versus pulsating quality, or a seemingly tiny difference in blood pressure between the two arms, how these subtle clues can completely change a life-saving decision in an instant? It's just such a powerful reminder that in medicine, attention to detail and considering the differential diagnosis, even when things seem straightforward, can quite literally change everything for the patient in front of you.